Thank you all very much. And I'm just reflecting on some of the points you've been making, and from Sally in terms of innovation, the tension in innovation, and seeking silver bullets is not the answer. From Nizam, getting the basics right is so important, and putting that greater focus on patient voice and patient needs. And we saw that coming out, Dame Joe, in terms of your experience, in terms of that is the only way to kind of create some sense of the chaos around us, is to kind of really focus on the people we care for. And I think what, Mark, really comes out from your overview is there's a lot in our gift. It's about choices, it's about decisions, and it may sound controversial to say, but actually, when there is no money, innovation happens. True innovation happens, right? Through greater focus as well. What I would like to do now is I would just like to open up the conversation to some questions which have been popping up. There's lots of questions, and let me just start off with the first point. Sally, coming back to you, you point in your conversation. You talked about let's not just go for the easy stuff. Technology, AI is a wonderful thing. Let's pump. If those are not the answers, what is, in your opinion?
Yeah, tricky one. So I'll probably give a slightly different answer on any day of the week, and a partial answer I think that Mark's also touched on is more clarity around what the priorities are, and Nizam, actually you also touched on it in terms of getting the basics right. But I think one of the questions I saw in the chat was what would be the kind of the wish list thing to be in the 10-year plan to really help move things forward, and I think it would be an explicit increase in primary medical care provision in the most deprived areas. I think in terms of how we're going to extract the most value. I say that very slightly caveated in that the evidence base on how you create the most value in healthcare is actually really complicated and tricky, and a lot of times it isn't at all clear. But we think that there's a lot of potential for heavy lifting to be done in primary care in deprived areas, and I would fund that by increasing decreasing the cost threshold that NICE applies when it's evaluating new technologies actually, so that would perhaps bring in some of that kind of the innovation born of scarcity that Mark's talking about. When there is no money, perhaps you get more valuable innovation. But I think if we really want to see some progress, then we need perhaps a bit of an experiment, because there's by no means guaranteed that increasing. We can't guarantee the returns on increasing primary care in poor areas. But I think that's that's our best chance of getting some progress.
And thank you, Sally. And I think you raise a very good point also, in terms of, we don't know if the solutions are going to work. But it's going back to what Dame Joe was saying, was, look, we learn the most when things don't go work, but we've got to learn from it and make things happen. In similar way, and if I can just follow up with you, Mark, the reality is it's a very political environment. The reality is if you're a chief exec or chair, dare I say, Dame Joe, sitting there, you've been asked to do lots of things. You've been asked to focus on the next 3, 6, 9, 12 months. Money is the only game in town. Cost improvement programs everywhere. Conversations between different providers and different carers across the different care continuum is getting challenging. But what you're talking about in your overview was the trapped value. Now, how do we actually achieve that, given the radical shift, balancing the here and now?
Yes, I mean, I think there's multiple related points in that. One is, when you apply pressure to the entirety of the system and have everybody searching for cost improvements, you naturally reduce productivity across the system. So I think a more targeted approach from the top in the first place would partially alleviate part of the problem, if I can be that controversial. I think then, there are aspects to this that say, if you start to look at patient data and what the patients actually need, it doesn't need to be huge radical change. it can be very small incremental steps. You start to look at the patient data and go, well, what's happening with our patients? You come up with some different ideas very quickly. So I completely agree with Sally in terms of there's some real benefits, I think, to getting more money to primary care, particularly for deprived areas. One trust I was working with recently, though, had probably not a unique situation where when we looked at which GPs their ED admissions were registered to, over half of all ED admissions came from 10 GP surgeries. Now, it's not that difficult for a trust, even a decent sized, mid-sized trust like this one, to pick up the phone to 10 GP surgeries and go, we need to talk. What can we do about this? So there are, that is not a seismic shift in healthcare. Yes, that GP surgery needs more funding for those 10, more spaces, more GPs to be able to help. But there is something wrong in the system at being able to look at that and go, okay, what's actually the problem here? Another example is that when you look at waiting lists, one of the really interesting things we see is that the attendance of people at ED who are on referral to treat wait lists grows at twice the rate of the wait list. i.e., people on the wait list, unsurprisingly, come to ED a lot more often. When they do come to ED, they're more expensive to treat. They're more likely to be, discharged to inpatient or moved to inpatient rather than sent home. They are more complex. That's not well understood within the system. So just starting to understand exactly who are these patients, what's happening to them, where are they going, you can start to unlock very tangible, specific actions that might just reprioritize your wait lists, or it might mean that you go and talk to specific GP surgeries, or it might be you say, okay, there's a particular problem with GPs referring children and young people in this area. You go and deal with those particular problems. You do those specifics to try and create some of the headroom then to the more fundamental pieces of change that we think are necessary, which is a full reorganization of the models of care around patient segments rather than around specific medical treatments or specialities.
Brilliant. Thank you, Mark. And your point about decisions, your point about putting the patient at the center, and it kind of resonates, Nizam, to what you were saying in terms of the change in practice and how you've seen things happening over the last few decades in terms of what's easy and what's harder in terms of dealing with patients. I wonder, Nizam, in terms of question, is the role of the clinician in terms of decision making and management, how do you see that evolving, and what would you like the NHS long-term plan to enable when it comes to clinicians and putting clinicians at the heart of decision making?
Yeah, well, I think if you look at clinical directors, I think the concept when they were introduced some 30 odd years ago was that you were putting clinicians in a position where they could direct some of the services and ensure that they ran properly. Unfortunately, the clinical directors have relatively little power. They take a lot of responsibility when things don't go well, but they don't actually have much power to easily shape and change services. And just as Mark was saying, there is some relatively easy things that can be done and changes that can be made when you look at the data and you focus on the patient and their journey. Yet it becomes very, very difficult for CDs to do that. So I would like to see them given more power. I'd like to see them given, for example, a small additional budget or a small part of the budget that they have discretion to spend without going through complicated business cases and so on. So if you like, some petty cash to make some easy changes. And I think also that they need to be held to account. What very often happens is everyone in a department says, okay, the position for CD is coming up. Who wants to do it? Everyone looks away and somebody is pushed into it, and they serve out their 3-year term or 6-year term or whatever. They need to be in a position where they are tasked with delivering certain things, and if they don't, then we say, thank you very much, it's time for you to move on, we need somebody else in.
Thank you, Nizam. I think the point there you're also making is reducing the distance between providing care for patients and making the decisions in terms of resources used to provide a great care. for those individuals as well. And I just wonder, Dame Jo, in terms of what we heard from Sally in terms of it's so important to start reallocating resources differently across, from hospitals to primary care, for example. We've kind of heard Mark talk about some of the obvious things right in front of us. We just need to have the courage to make those decisions, get on with it. And we've heard from Nizam in terms of the role of clinicians, in terms of making things happen. I'd love to kind of hear from your perspective, from a board perspective, in terms of how does the NHS leadership make this happen, enable this to happen? How do you create that headroom, the term Mark used earlier on? How do you create that headroom in boardrooms to make the changes that are needed for local communities?
Oh gosh, what a question. Well, there's a question in the chat as well about, how can we do things differently? Is the current situation in terms of leadership appropriate? I do think actually, the accountability, the governance has to be clear, and there's no doubt about it, it's public money. But we're trying different things. Our clinical leaders attend our board, and so there's real accountability and ownership there. And I suppose the other thing that we're trying is we have a strategy board on a quarterly basis. So we're trying all the time to maintain a focus on the vision, looking at innovation and opportunities, as well as how we begin to think with our partners about investment in neighbourhoods and neighbourhood teams. So we're trying to do that whilst at the same time keeping a real focus through regular board meetings on the use of quality assurance in the bottom line. So all the time you're twin tracking, and I think our role right across the board, it's a team approach. It's for all of us to try and keep our heads up, take people with us, delegate where we can, and really listen, ward to board, what's coming up, engagement. So, these are all management buzzwords, but the challenge for us to make it feel real for people within the trust, and right at the heart of it, listening to our patients and their families all the time, getting feedback from what works for them. But, the points that have been made about different, the way clinicians work has to be different. And that's why the clinical leadership is so important.
No, thank you, Jo. And I think one thing which came across from your answer and your talk was the idea of hope. It's pretty doom and gloom, but what can we do? What's in our gift, and how we can motivate people to do things differently. I was going to end the Q&A with a question, but I had a question, but I think it's an even better question on the chat. And what I'd love to do is to ask that question and get each one of you to respond in your order, in the order you presented. And the question somebody's put up on the chat is a brilliant one. It is, what are the positive messages that you want the NHS to take from this webinar? So if I can start with Sally.
Yeah, really interesting and important question, and I'm going to follow on a little bit from what Dame Jo has just said. I think that the positive message does lie in the public accountability and ownership of the NHS, because I'd say that there's an unanswered exercise that the NHS hasn't done with the public, which is to really talk to the public about the opportunity costs and the trade-offs involved in managing the NHS budget. I think politicians are terrified of asking the public those questions, but I think they might be surprised if the NHS can manage to have, really detailed and informed engagement with the public about, the cost of adopting this new technology. Well, we can do that, and these would be the benefits, and this is who will benefit from it, but these are the things we won't be able to do. And I think that healthcare for children, for example, amongst the Joe public, would probably be given a much higher priority, just as one example compared to what it receives at the moment. So I think my positive message is that there are things that the NHS can do that it hasn't really tried doing it, probably because of lack of the political courage to do so.
Brilliant. Thank you, Sally. Nizam.
Yeah, I think I see things as actually quite positive, because I think what's coming out from this is that there's a huge amount of trapped value, and there are huge opportunities, as Mark said, for us to improve things. And I would say that really depends on 2 or 3 key areas. Data is absolutely critical. The data is there, it's not used. We can collect more of it, but we're not really using the data that we have adequately. So I think using the data appropriately is really important. As I said earlier, I think encouraging people to innovate and try different things is absolutely essential, and we must be prepared to take some risk in doing that. And I think a more strategic approach with better contingency planning, I think, is also something which should underpin all of that.
Wonderful. Thank you, Nizam. Dame Jo. So, Joe, you're on mute.
Sincere apologies. Absolutely endorse what's been said before. Using data, understanding your communities and who it is you're serving is so important. And I really do think we have to help the NHS understand that single agency approaches to health are just not going to work. It is about well-being and the lifestyle issues and socio-economic factors which impact on health and well-being, and that's another conversation with our public, I think, that is so important. Thank you.
Thank you. And Mark.
Yeah, thank you. I mean, Nizam has already said much of what I was going to say, but I'll phrase it slightly differently. I think there's sometimes a narrative that the NHS is out of money because, due to the aging population, due to improvements in healthcare, we're simply doing everything we can and we now have to start cutting services. So I don't subscribe to that idea at all. I think there is money in the system, right? When you have huge trusts who are being outperformed by the Isle of Wight, no disrespect to the Isle of Wight, but I can understand why they might be lower down the scales, right? When you have huge trusts being outperformed by the Isle of Wight, you go, okay, we need to do something differently. And what I see as a real positive is that something different would ideally be around the actual needs of the patients and thinking about how healthcare is properly designed and delivered in a way that just, naturally the NHS has not been from its formation in 1948 onwards. It just hasn't had that opportunity. We now, I think, understand enough to say, right, let's take a patient-centric view and bit by bit we can improve. That for me is a really positive message.
Wonderful. Thank you. Thank you, Mark. And apologies to those who've asked some questions we haven't got time. So we're out of time, unfortunately. So I just want to remain to say thank you all very much for joining the webinar, and very special thanks to all our speakers. Please do look out for the recording and the summary Q&A, which will be on the website soon. And also do please subscribe to the Stras's Thinking Different newsletter and the wonderfully titled Friday Fish and Chip weekly newsletter by my esteemed colleague, Dr. Nadeem Morgul. Great sources of learning and development for healthcare leaders. So please also do fill out the feedback survey. It will only take 2 minutes. It's really important to us because it helps us to improve these webinars going forward. And finally, our next webinar is on the 9th of September, and we'll be talking about rewiring the NHS around childhood. So please do register, and we look forward to seeing you there. So thank you all very much.